Hello, my name is Jessica Watson, and I'm here to show you an incredible opportunity that awaits your prestigious university. You as faculty and staff have already put in the long hours, great requests, research, and preparation to make your state-of-the-art simulation lab what it is today. I'm offering you a break from the tedious work you have already put forth. Each of you knows the amount of effort and time it takes to create a simulation experience for your students. If this time were allotted for other resources, think about what advantages can be made in other areas. To eliminate this, I have created a simulation experience for you. Not only have I already created a detailed simulation plan for you to follow, I have also created a simulation that each and every single one of your students needs to help make them a successful nurse upon graduation. As experienced faculty, you probably remember the first emergency code situation you were in with those credentials behind your name, registered nurse. Instead of being a bystander watching anxiously, you are now the person responsible for your patient's life. Stressful, scared, somewhat clueless? I'm sure each of these emotions rush through you, and these same emotions will rush through your students as well. But what if you could help prepare them for that day, the day their patient will become unresponsive and their heart will go into a lethal arrhythmia? With the simulation I have designed, you can do just that. If you're thinking, that's what clinicals are for, I would completely agree with you. Nothing can replace full clinical experience. But how many of you know for a fact your students have seen a code situation during clinicals? And if so, what was their role? I know for me as a student, we were lucky if we could sneak into the corner of a room and maybe jump in line to do chest compressions. While those are still great experiences, don't your students need more? Soon they will be the nurse responsible to adequately care for the patient and make life-saving decisions. More preparation should be done. The learning objectives for this simulation will address these concerns: managing the care of a myocardial infarction patient, displaying patience and understanding toward patients and their families, and to manage the care of a patient as a team. All of these are important, needed skills your students can obtain and improve upon with this simulation. To make the most of this simulation, we will ask students to do preparation work. Studies have shown when students are better prepared, students have better overall learning outcomes from the simulation. We will ask students to review pathophysiology pages in their student textbook regarding cardiovascular function. We will also ask them to review their pharmacology pages for morphine, nitroglycerin, epinephrine, aspirin, Plavix, and warfarin, all medications that will take part in the simulation. Next, we will instruct students to review the importance of confirming physician orders and communicating with family members. We will also ask them to review placement of 12-lead EKG leads. And last but not least, which should let students know what they will be facing, we will instruct students to review basic life support protocol and assigning jobs during a code situation. The setup of the room will be a basic emergency department room, or any basic simulation room you have will do. The star of the simulation will be a high-fidelity mannequin you already have here at your facility. For our simulation, we have named him Jim. Jim will be in the stretcher, decked out in his Alabama football team attire with his wife at the bedside. A TV will be playing an Alabama football game loudly as your students enter the room. For equipment, you will need a vital sign monitor in the room. Cardiac leads, saturation probe, blood pressure cuff, nasal cannula, and thermometer will all be in the room but are not attached to Jim upon arrival. Behind Jim's stretcher will be an oxygen flow meter already attached to the wall. Most students aren't familiar with taking on and off flow meters at this point, so to alleviate unneeded stress, our simulation design eliminates this factor. Also in the room will be an IV start kit, IV pole, IV pump, pressure bag, and an ambu bag with face mask. Equipment outside the room will be a crash cart stocked with epi. There will also be an EKG machine outside the room. During pre-briefing, you will explain the learning objectives to the students, as well as cover basic information such as bathroom locations and expected time of overall simulation. You will also stress to students the importance of creating a safe learning environment. The script provided for you as faculty clearly explains how to put students at ease before entering what can be a very intimidating environment for students. The script points out that no one here is to be critiqued or faulted, and students are encouraged to be brave and think critically. Students are also made aware of the Honor and Confidentiality Code and how serious this is taken here at the university. Next, you will explain the basic functions and expectations of your mannequin, such as best locations to feel pulses, hear heart sounds, and lung sounds. Even if your students are well versed in physical assessment, if the functions of your mannequin are not clearly explained, your students will not have a successful simulation experience. And lastly, you will introduce to your students who your embedded simulation person will be and their role in the simulation. For those of you who aren't familiar with an ESP or have never used an ESP during a simulation, this is your students in the room go-to person to answer questions. If your students think they hear wheezing sounds, they can ask the ESP. If the students don't know where to find the crash cart or nasal cannula, the ESP helps do that as well. An ESP never does anything without being asked and never gives their opinion. This is simply a person to help navigate the simulation scenario. Students have better simulation experiences with an ESP, in my opinion. Now, to begin the simulation. Your ESP will approach the students as they enter the room, saying, "Hey, you've been assigned Mr. Larry Combs. He's right over there in bed 1. He just came into the ED complaining of chest pain. I haven't had a chance to assess him yet. Do you think you can go look at him?" So, Larry Combs presents as a patient in the emergency department, forced by his anxious wife, which will be sitting at the bedside. Larry is complaining of heartburn, but he accredits his heartburn to fried foods and spicy salsa he ate eating at a tailgate party earlier in the day. Larry is much more calm than his wife. All the while, he is truly having a myocardial infarction. Larry is much more concerned with watching the football game, which is playing in the room loudly during the simulation. There is a remote in the bed. Students can turn the volume down or off if desired. His wife is very anxious for Larry and desires that he stop watching the football game and focus on what's happening to him. Larry is very involved in the football game at this point, but he is still exhibiting shortness of breath, chest pain, and is diaphoretic. Larry accredits all of this to the game being so close and that Alabama is losing. Little does he know, it's still the first half of the game. Throughout the simulation, Larry will yell, but he is yelling for good or bad plays during the game. When he yells, his wife will jump up, startled. Larry provides comic relief for what can still be an intimidating situation for students, but Larry also demonstrates chaos students will encounter as nurses and gives students experience at focusing on critical needs despite the chaos. If students put Larry on a monitor at this point, all of his vital signs will be within normal limits except for his heart rhythm, which will be in atrial fibrillation, and his blood pressure, which will be low. If the students do recognize this, Larry will say he does have a history of chronic AFib. If further probed, Larry will also state the medications he takes at home for this: Plavix, warfarin, baby aspirin, but he also admits that he's not compliant with his medications. The monitor will show a low oxygen saturation. If the students apply a nasal cannula, Larry's O2 will increase. 2 minutes after being in the room, an MD, which will be part of the simulation, will appear to quickly look at Larry and be slightly annoyed at his football obsession, and give verbal orders to start an IV, draw labs, which included troponin and CKMB levels, and apply O2 6 liters nasal cannula, and obtain a 12-lead EKG. If students do not have Larry on a monitor before the MD arrives, he will instruct the students to do so and then give the verbal orders. Lab results will be given back within seconds on an iStat monitor as follows: troponin of 7, CKMB 50. Students should quickly realize that these lab values are indicative of myocardial tissue damage and immediately page the MD with results. After the MD has viewed the EKG and lab values, verbal orders will be given to start an IV of morphine, give nitroglycerin tablets under the tongue, and a chewable aspirin. Whether the MD is paged or not, as the simulation progresses, the cardiac monitor will slowly lead up to Larry going into a lethal arrhythmia. Larry will begin to seem more tired and less energetic about the football game. Larry will begin an AFib and then develop PVCs. The PVCs will then increase to bigeminy, trigeminy, and eventually he will progress into pulseless VTAC. As this progresses, his blood pressure will drop. If the students page the doctor within 5 minutes of the beginning of the simulation, Larry will go into VTAC with the MD present. The MD will then run the code. If the MD is not present, students should still begin BLS protocol and begin CPR. Orders given during the code will also include giving bolus fluid through a pressure bag and starting another IV. Team members should each take a role. If the students fail to obtain an EKG and/or put Larry on a continuous cardiac monitor, Larry will still continue to decompensate until lethal arrhythmia. Larry will then be unconscious, but students should then identify that Larry does not have a pulse and he isn't breathing. Once Larry has a lethal arrhythmia or is unconscious, a code will be called and students will initiate BLS. After doing 2 rounds of chest compressions, applying defibrillation pads, shocking, and giving epi, Larry will gain a last sustaining rhythm and will be transferred to the cath lab for stent placement. The type of debriefing you will be using is advocacy inquiry questions. Just as a review, and for maybe some of you who are not familiar with AI questions, the basis of advocacy inquiry questions are: I saw, I think, I wonder. This frame of debriefing still allows you to mold the conversation, but allows your students to give their frame of mind. We as instructors want to know the why of a student's rationale. This is the best way we can further teach and advise. For you as faculty, this also helps shift the mindset from lecturing about what is right and wrong to an open field of discussion. So here you have it, the basics of a pre-planned, detailed simulation you and your faculty can use. The time and planning has already been done, saving you hours of time you could be spending catching up on grading, answering email questions, and preparing for your next lecture. Not only that, this is a scenario your students need to be exposed to. Thank you for your time and consideration in partnering with me to make your students better prepared nurses and ultimately helping the outcomes of patients.